يعني بجد it is my pleasure to be with you today, and I'm going to share with you our experience regarding the management of pediatric DKA. It is one of the common problem we come across all of it as the pediatricians. It is not an ordinary lecture. I'm going to concentrate in certain point while you are managing a case with diabetic ketoacidosis. If I'm talking fast, you can stop me at any times. طيب, we can start by this case scenario. This is a 12 years old girl, non case of diabetes for 4 years. She's on Lantus 20 unit and Abidra 6 unit for breakfast and 8 unit for lunch and 7 unit for dinners. She presented to emergency department because of abdominal pain and vomiting for the last 12 hours. She is dehydrated with glycemic scale of 13. And her RPS, her random blood glucose is 550 milligram per deciliter. At time of presentation, her pH showed pH of 6.8 and bicarb of 5. Urine dipstick shows 3 cross of ketone and 3 cross of glucose. For sure, we don't have doubt about the diagnosis, but certain questions usually they cross our mind whenever you come across such case. So after finishing this presentation, we are going to answer the following questions. So the question we need to answer is this patient having DKA or not? What investigation I need to do? Which fluid I'm going to use and how much I give over how many hours? When to change and to stop fluid? When should I start insulin? Which type? What is the dose? When we stop this insulin? When to give potassium? How much I give? Any contraindication for these potassiums? Do we need to give bicarbonate for this patient who presents with severe acidosis? And how I'm going to monitor this patient? And is this patient need BIC or not? And when to say my patient is out of DKA? So this is the questions usually it crosses the mind of any one of us when he come across a patient with DKA. So we try to answer some of this question, inshallah. First, we start by the definition of DKA. It is a clinical syndrome characterized by, for sure, we need a blood glucose of 200 milligram or more. We need a glucosuria, that is 3 cross or more. We need ketonuria, is a 2 cross or more of ketones. And we need ketonemia. A ketonemia is a ketone bodies that is measured by the ketonometers. And as we know, we have 3 ketones. We have the beta hydroxybutyric acid, and this is the one usually we measure by the ketonometer. So for DKA, we need a level of beta hydroxybutyric acid of 3 millimole or more. And for sure, in addition to all that, we need fluid, electrolyte, and acid-base disturbance. So the patient for sure must be dehydrated and having electrolyte and acid-base disturbance in a form of pH less than 7.3 and bicarb less than 18 millimole. Maybe the 18 millimole as a figure, it is a little bit a new figure to some of you, because the previous figure, which you know for all of us, is a 15 millimole for the bicarb. But the recent guideline, according to SPAD guideline, the recommendation is changed to 18 millimole instead of 15 millimole. So this is the definition of diabetes ketoacidosis. So we come to the pitfalls in the definition itself. Not any hyperglycemia with ketonuria is DKA. For sure, all of us, we come across a child, non-case of diabetes, he come to the ER having hyperglycemia due to any stressful factor, like in form of having tonsillitis, whatever cause of infection. So you measure the blood glucose, it finds 500, but when you measure the ketone, the urinary ketone, you found 1 cross, the patient is not dehydrated, and when you do the VPG is normal. So hyperglycemia with just 1 cross of ketone, this is not DKA. Another point, a normal level of consciousness does not exclude DKA. So it is not a must to have a low glycemic scale to say this patient having DKA. And the third point, hypoglycemia with ketonuria is not DKA. Sometime in the ER, you may come across a child, maybe he's not non-diabetic, but he presents with hypoglycemia. When you measure the ketone, you find that he's having 1 ketone in the urine, and this is usually starvation ketosis, and this is not a DKA. Be aware of DKA with compensated metabolic acidosis. And this is group of children who, when you come to the ER early, usually they have a normal pH. So the pH will be 7.3 and above, but their bicarb, it will be in the lower side. So this group of children, they're having a compensated metabolic acidosis with the DKA. And the latest one, is be aware of aglycemic ketoacidosis. It is not common, but you may come across them. This is a group of children, non-case of diabetes. They having symptoms suspected of DKA, and their parent at home starves them from any carbohydrate. This is one of the explanation. Or they give them a huge dose of insulin at home, especially the rapid acting one. So when they come to the ER, their blood glucose may be less than 200, but they're having a blown picture of DKA in form of dehydration, and their VBG is showing metabolic acidosis. Type. We come to it is important to classify the severity of DKA and what is the practical point of classifying the DKA, because when you decide to say this patient having moderate, mild, or severe dehydrations, usually you cannot judge clinically, because the judgment clinical is not an objective. So you can say this patient is having sunken eye, other one he said skin patch, go back very slowly. The point usually we know about the assessment of dehydration. So they agreed that first you have to say mild, moderate, and severe. And based on the degree of the severity of DKA, you will determine the deficit. So those who have mild DKA, usually they need 5%, they have 5% deficit. And those who have moderate DKA, usually they have 8% deficit. And those who have severe DKA, they have 10% deficit. So the utilities or the practical utilities of this severity of DKA is to determine the deficit of the fluid you are going to give. Muhammad, الصوت still is okay?
Yes, Dr. Bashir, we can hear you. Continue, please.
Okay, tamam. Clinical manifestations. When we come to the clinical manifestation, the patient, he may have a classical symptom of diabetes in form of polyuria, polydipsia, and others. But for sure, the patient is going to be dehydrated. He's having tachypnea in form of cosmal respiration. And when we say cosmal respiration, this is a rapid deep breathing. It is not rapid shallow breathing, because the rapid shallow breathing is the breathing we saw in a patient having pneumonia. But this is a rapid deep breathing, what we call the cosmal breathing. This is an acidotic breathing. Again, the vomiting and abdominal pain, confusion, drowsiness, and loss of consciousness may be present, in addition to classical symptom of diabetes, as I mentioned. طيب, اجرى practical point. Not all children or caregivers volunteer classical symptom of diabetes at time of diagnosis. So not all children or caregiver volunteer classical symptom of diabetes at time of diagnosis. And here we are talking about the newly presenting case. Therefore, finger strict blood glucose measurement should be considered for all children present with rapid breathing. So any child have rapid deep breathing, even if the mom is not giving you any history suggestive of diabetes, please check the blood glucose. Any child he present with vomiting and abdominal pain without diarrhea, please check the blood glucose. And this is very important for practicality and again for medico-legal issue. So this is the new recommendation from the SPAD guideline 2022. Goal of the therapy. So when you have a patient with DKA, what your goal of the therapy? For sure, you need to correct the acidosis and reverse ketosis. You need to correct the dehydration and electrolyte, and you need to restore the blood glucose to near normal, and to monitor for complication of DKA and its treatment, and to identify and treat any precipitating event. Identifying and treating any precipitating event is a paramount. Why for? Because if the patient non-case of diabetes and he presents with DKA, and if you don't elicit or you pick up the cause behind this DKA presentations, he will come back again by the same scenario soon. So you have to look for the cause, the precipitating factor, and you have to treat them. So the emergency assessment, when you see the patient, for sure you took history very quick. You ask about the classical symptoms, and you ask about the vomiting, weakness, confusion, history of fever, and if the patient non-case of diabetes, for sure you ask about the medication history, because especially among those who are adolescents, usually they miss their dose. Then you do quick examination. You have to measure the weight and you assess the dehydrations. You check the vital sign for sure, the pattern of breathing, the smell of the ketone, and we know not all people that can smell ketone. Even me, I cannot smell it. So if you don't smell it, it doesn't mean that it is not there unless you are the one who can smell the acetone. Glasocoma scale, for sure you check, and if the child is febrile, look for the focus, and especially in those who are non-case of diabetes, if they are presenting with fever, check the site of injection. Maybe there is abscess there. So the examination of the injection site is very important. Come to investigation, the blood glucose, the BBG, the blood glucose, the VBG, the ketone, the UNE. If febrile, took culture. So you took a swab culture, throat culture, urine culture, and blood culture. A1C if the patient is not non-case of diabetes, and other investigation if indicated accordingly. So this is the initial labs that you need to assess. And then based on this data and the history examination, most likely you are determining your patient is having diabetic ketoacidosis. For sure, you need to consult or to inform your seniors that I have patient with DKA, and you need to consider PICU admission after stabilization, and we come soon to the when you consider PICU admission. Hey, then when you come to the hydration status, usually we said you have to assess the hemodynamic status of your patient. And then you categorize your patient to two groups. Those who have uncompensated shock, and those who have compensated shock, and those who are not in shock. So either there is no shock, this is a group, or there is group who have shock. And those who have shock, either they have compensated, and we define the compensated shock by those who have a rapid, weak pulse with a bronchopulmonary feeling, but the blood pressure is normal. And those who have uncompensated shock, for sure, all of us, we know the blood pressure is going to be affected. And those who have just having dehydration without shock. So for uncompensated shock, for sure, what you need to do, sorry, for those who have dehydration with compensated shock, so their blood pressure is maintained, you give a normal saline in a form of 10 to 20 ml per kg over 20 to 30 minutes and repeat it as needed. This is a new guideline. The previous guideline mentioned you have to give this saline 10 to 20 ml per kg over 30 to 1 hours. But the new recommendation is to give it over 20 to 30 minutes, and you repeat accordingly and according to your patient need as per your assessment. Correct fluid deficit over 24 to 48 hours, and you add potassium chloride 40 millimole per liter. If the patient having uncompensated shock, for sure you do the pulse guideline, and you resuscitation, the airway, plus minus NG tube if the patient is comatose, especially if the abdomen is descended. You give 100% oxygen, and you need to give saline in form of 20 ml per kg as quick as possible, and you repeat until the circulation is restored. Some group of children, they may present in the ER having minimal dehydrations. So the deficit is around 5%. So they are having minimal DKA, tolerating oral fluid. What I'm going to do? So this is people with the minimal dehydrations. The management is different. How different it is? You can start. We don't need to give boluses. You can, and the patient having a mild DKA, as evident by VBG is between having bicarb between 10 and 18, and the pH between 7.2 and 7.3, and the patient tolerate orally. So this group of children, we don't need to give them IV fluid. How they can manage them? So is that you can start the therapy with sub-Q insulin and continue oral rehydration. If the patient not improve, then you can move to IV fluid and to IV insulin. Right. For sure, you continue the insulin infusion at a rate of 0.05 to 0.1 unit per kg per hour, and usually we start 1 hour after fluid initiation. We come to a little bit details about the potassium, the fluid, and the dose of the insulin. Right. Critical observation, for sure you need hourly blood glucose, fluid input and output, neurological status at least hourly. You need to check the electrolyte every 2 hours after starting the IV fluid, and you need to monitor the patient, putting the patient in ECG monitor to look for the T wave because of the issue of potassiums. Sometimes you start your management and everything goes in the right track, and then you assess your patient 4 hours, 6 hours later, you find that the patient is not improving. Improving in what sense? The VBG is not improving. So if the VBG is not improving after 4-hour pass from your management, certain things should cross your mind, and you have to assess these three things. First, re-evaluate the IV fluid calculation, and is your patient need additional resuscitation or not? And this is really, it is a very common scenarios. Usually we receive consultation from our colleague in the ER for a patient who was starting the management, and then for 6 hours, they call us. This patient is not improving. His VBG is static or worsening. The first thing, if you ask him to check the capillary refilling, most likely is going to be prolonged. So if your patient is not improved for 6 hours after you start the management, the first thing to do is to check the capillary refilling. Is the patient need more fluid or not? And if your patient need more boluses, give him the bolus and check the calculation of the fluid. Is it the right? Is your patient receiving the amount he need or not? This is one probability. What will be the second probability of acidosis not improved? The insulin itself. So how I know the insulin is the cause? To know the insulin is the cause from the beginning, check the blood glucose dropping, because our target is to drop the blood glucose by 50 to 90 milligram per hour. So when you start the management of DKA, usually you need the blood glucose to drop down by 50 to 90 milligram per hour. We do not need it to exceed 90, and we don't need it to be less than 50. So if you check the blood glucose and you find that the blood glucose is not dropping by the rate you expect it to be, so the issue is the insulin. And in this point, you have to check the dose. Is the calculated dose really given for the patient? You have to check the line. And everything is okay concerning the insulin. You can increase your dose. If you start by 0.1, so you can increase the dose by 20%. So to summarize this point, if the patient is having issue of not dropping down the blood glucose and the calculation dose is okay and the line is okay, you can increase the running dose by 20%. Example, if your patient is running in 0.5 unit per kg, you can go up to 0.12 unit per kg. One of the things you need to consider at this point, again, the sepsis. And the difference between pediatric and adult is usually pediatric, if they're having sepsis, most of the time they manifest this sepsis, because adults who have poor control diabetes, they may not mount out fevers. But the case is not like in pediatric. Most of our children, when they're having fever, they mount out the fever. And if you have fevers, for sure, you have to consider the sepsis and you have to start the antibiotics. So this is how you think or how you tackle out a patient who's not, his VBG is not improving after 4 hours. Right. Coming back to observation, you check the blood glucose, and if the blood glucose drop down less than 300 milligram per deciliter, you need to change your fluid from normal saline to dextrose 5%. So the two, or if the blood glucose fall by more than 90 milligram per deciliter per hour. So this is the two situation in which you need to change the fluid from normal saline to normal saline with dextrose. So you change to have normal saline or full saline, and you add glucose to fluid ranging from 5% up to 12%. Usually we start by 5% to prevent the hypoglycemia. So one can ask me questions. Doctor, if my patient is starting management by a blood glucose of 600, and then I find he's dropping down rapidly, and now his blood glucose was 420. Can I add the glucose at this point with a blood glucose of 420? The answer is yes. Why? Because if you don't add glucose at this point, he is going to develop hypoglycemia. Right. If your patient is now clinically well, ketosis is resolved, tolerating oral fluids, you can decide my patient is out of DKA, and you can start the sub-Q insulin and then stop the IV insulin after appropriate interval, and we'll discuss it in a minute. Warning sign while you are managing your patient: if the patient having severe or progressive headache, this is a warning sign of cerebral edema. And some children, when they present initially, they present with headache. So the headache at presentation is not a warning sign. Usually this is because of dehydration and acidosis. But if this headache resolve and then appear again, or it is not resolved and got worsening, this is a warning sign. Slowing of the heart rate, again, is a warning sign. Irritability, confusion, decreased consciousness, incontinence, and certain specific neurological sign, this is a warning sign of cerebral edema. And if such sign appear, first thing you need to exclude hypoglycemia, because hypoglycemia usually its symptom can mimic cerebral edema. And if you get sure your patient is not having hypoglycemia, you can consider cerebral edema, because this is one of notorious complications, and you manage them accordingly, and we come to the management of cerebral edema, inshallah, soon. But the practical point, intubation should be avoided if possible, and unless necessary, avoid placing central venous catheter. If inserted, it should be removed as soon as the patient clinical status permit. And the new recommendation, if you insert central venous line, mechanical and pharmacological prophylaxis, low molecular weight heparin, should be considered for those with central venous catheter, especially in children who age more than 12 years because of risk of thrombosis. And give antibiotic to febrile patient after obtaining appropriate cultures. And bladder catheterization should not necessary unless the child is unconscious or unable to void in demand. Type. Where should the child with DKA be managed? After initial life support, the child should receive a care in a unit that has experienced nursing staff trained in monitoring and managing DKA in children, and access to laboratories that can provide frequent and timely measure of biochemical variables. Type. Sometime indication for PICU or a unit that have an equivalent resources and supervisions. Children with severe DKA, they need to be admitted to PICU. It is if the bed is available, and children at increased risk of cerebral edema, again, this group, they need to be admitted to PICU. Where geographical constraint requires that the management can be initiated in a center with less experience and with few resources, there should be arrangement in place for the telephone or video conference support from a physician with expertise in DKA. Yani, sometimes some of our colleagues may working outside the big city. So, and they work in a place where there is no endocrinologist, and you come across patient with DKA. You can take your phone and you can call the endocrinologist in a nearby city, and you can talk to him concerning the management. This is the point. طيب. نجي الفلويد and salt. Patient with DKA have a deficit of extracellular volume that is usually ranging from 5 to 10%. And as I mentioned, clinical estimate of the volume deficit are subjective and inaccurate, and therefore in mild DKA it is 5% deficit, and in moderate DKA 7%, and in severe DKA is 10%. طيب, fluid and salt, calculation of fluid infusion rate for obese children should be similar to those for other children, because nowadays we saw a lot of children who having type 1 diabetes, but the obesity itself is something epidemic. So you can have a child with type 1 diabetes, he present with the DKA, but he's obese. So when you come to calculate the fluid, you calculate it as other children. If the fluid calculation for obese children exceeds those typically used in adult protocol, then the adult DKA fluid protocol can be used, اللي هي 1 liter maximum per bolus. You don't exceed the 1 liter for a bolus, and the rate of infusion not exceed 500 ml per hour as fluid maintenance. طيب, principle of water and salt replacement. في recent RCT randomized control trial is very interested, and their conclusion is neither the rate of administration nor the sodium chloride content of the intravenous fluid significantly influence the neurological outcome. So therefore, clinicians should not be unnecessary restrict fluid administration if the clinical signs suggest the need for circulatory volume expansion. يعني in a simple Arabic, the clinical judgment is what we need. So if you give 3 bolus and your judgment is your patient needs more bolus, give him more bolus. Right. Important point, concern important questions. يعني usually when come to fluid, what type of fluid? For sure we give usually normal saline or ringer lactate. How much fluid? Usually, as you know, we calculate the deficit plus the maintenance over 24 to 48 hours. Over how many hours? Usually 24 to 48. And when to change the fluid, we mention it if the blood glucose drop by less than 300 or rapidly drop. And when to stop, for sure, if the patient is tolerating orally, he's out of DKA, we can stop the fluid. DKA with hypernatremia, this is one of not rare, but you can come across them. This is a patient who presents by DKA, but you check the sodium and you find more than 150 millimole. The management is the same, except you use 0.9 saline with chloride and potassium, but you correct the fluid over 48 to 72 hours. Hyperchloremic metabolic acidosis. Again, the hyperchloremic metabolic acidosis, this is one of the complications usually happen. It is due to use of large amount of chloride-rich fluid. How we define it? The definition is the ratio of chloride to sodium. If we divide the chloride over the chloride and sodium, the ratio usually more than 7.9. And the patient having metabolic acidosis. What is the problem of this? It masks the recognition of resolution of ketoacidosis. How clinically usually we saw the patient, you find you start your management, the patient is improving, you might find that the pH is normal, but the bicarb still is low, the patient clinically is well, is not dehydrated, is not having acidotic freezing, but the VPG is not normalized. Usually, most likely, you have hyperchloremic metabolic acidosis, check the sodium and check the chloride, and you can divide the chloride over the sodium, and you come up by this result, consider hyperchloremic. But the diagnostic test is if you have the measurement of butyric hydroxybutyrate, because this one, in this, when we starting the management of DKA, usually the level, as I say, 3 millimolar and above. But if the patient is out of DKA, usually the level is less than 1 millimole. So if I confirm my patient is having hyperchloremic, what I need to do? You need just to change the fluid to have saline instead of full saline, and you can use the potassium acetate instead of chloride, the potassium chloride, or you can use fluid with ringer lactate instead of normal saline. Type potassium replacement. Children with DKA suffer a total body potassium deficit, usually of 3 to 6 millimole, and a total body potassium usually deficit, but at time of presentation, the patient may have a potassium level that is normal, increase or decrease. So the all probability is there. Potassium replacement if hypokalemia type. So the practical point when to give potassium, usually we start potassium when I start the insulin. So when you start the insulin, you start the potassium. How much? Usually we give 30 to 40 millimole per liter of fluid. What is the maximum rate? Is 0.5 millimole per hour. When to stop potassium? If the patient is out of DKA and his potassium is normal, you're sure you are going to stop the potassium. Any contraindication? Yes. What is the contraindication? The contraindication is if you connect your patient to ECG monitoring and it showed evidence of hyperkalemia. That means peak T wave. This is contraindication. Don't give potassium. And if you measure the potassium and it come back to be more than 5.5 millimole, this is relative contraindication. Don't give potassium. And the third contraindication, before the result of potassium is available, if the patient is not passing urine and the renal function is not yet. But usually we recommend, if the patient is not passing urine, check his bladder, because he may have a distended bladder, especially in those who are non-case of diabetes. They may have some sort of neurogenic bladder and they have a full bladder. So if the bladder is full, that means the kidney is function. You can start the potassium. So this is the 3 relative contraindication. If the potassium is more than 5.5, you need to repeat it in hourly basis. When it's normal, start giving the potassium. The second contraindication, if the ECG showed evidence of hyperkalemia by peak T wave. And the third contraindication, if the patient's not passing urine and you examine the bladder and it is empty and you don't have renal function at your hand. طيب, the insulin therapy. طيب, insulin therapy is essential to restore normal cellular metabolism, to suppress lipolysis, ketogenesis, and normalization of blood glucose concentrations. The recent randomized controlled trials in children less than 12 years old show that a dose of 0.5 unit per kg was comparable to standard dose of 0.1 units. So you can use either 0.1 or 0.2. So is there any group of children do you recommend to use 0.5 unit instead of 0.1? The answer is yes. Which group? Those children who are less than 5 years of age, or usually you can start them in a small dose. And those children who have a small, have mild DKA, mild to moderate DKA, you can start them in a small dose. And those children who know case of diabetes, and their mom, when they come to ER, they tell you, just 1 hour ago, I give him his rapid acting insulin. So he's having active insulin in his body. So you can starting by 0.5 instead of 0.1, and then you escalate the dose if the patient is not responding. Practical point is when to give the insulin. Usually you give it 1 hour after starting the fluid. Which type? Usually we give the regular. What is the dose we mentioned? How frequent? It is hourly. How you prepare insulin? It depends on your local protocol, but usually we bring 50 units of insulin with 50 ml of normal saline. We mix them and we put them in the insulin pump or syringe pump. When to stop the hourly injection if the patient is out of DKA. Practical point, increase insulin dose if the expected rate of biochemical improvement does not occur. So if I mentioned, as I mentioned, the dropping is not by the 50 to 90 milligram per hour, increase the dose, and usually increase by 20%. And if the patient show marked sensitivity to insulin, the dose may be decreased, provides that metabolic acidosis continue to resolve. Yani, if the patient, you start him on insulin and he show marked sensitivity, check the VPG. If the patient his acidosis is improving, you can reduce the dose. But if the patient his acidosis is not improving yet, give more dextrose. Type time on IV insulin infusion and dose of insulin should be minimized to avoid severe hypokalemia and hypoglycemia. And it is well known that insulin it is have aldosteronic effect. In circumstances where continuous IV administration is not possible, and in children with uncomplicated mild to moderate DKA, you can start the sub-Q insulin, and usually you give it hourly or 2 hourly sub-Q rapid acting insulin analog. This is the Novorapid and the Abidra and the Humulog. Insulin Lispro or insulin Spart is a safe and maybe as effective as IV regular insulin infusions. The dose is 0.15 unit per kg every 2 hours. So the dose is 0.15 unit. Type a situation, sometimes you have difficulty in lines. You have difficulty in line, and you know all of us as Sudanese in Sudan. I don't know the current situation, but previously we don't, and in most of the center we don't have the infusion pump. So we start giving our patient IV and sub-Q insulin instead of the IV insulin, and we leave the IV line for the IV fluid. Acidosis, control trials have shown no clinical benefit from bicarbonate administration, and severe acidosis is reversible by fluid and insulin replacement. The only situation in which you can consider giving the bicarb is life-threatening hyperkalemia or severe acidosis, a pH less than 6.9 that has compromised the cardiac contractility. And we mean by the cardiac contractility, so this patient having refractory shock, he received the fluid, he received the inotropes, and he is not responding. In this case, you can start giving the bicarbonate in a dose of 1 to 2 millimole per kg over 60 minutes. And the rationale behind giving the bicarb in this patient is severe acidosis may interfere with the action of the inotropes. Type complication of therapy, hypoglycemia, hypokalemia, hypercholoremic metabolic acidosis, inadequate rehydration, and cerebral edema. Clinical and biochemical monitoring. Successful management of DKA require meticulous monitoring, and it is pitfall if you don't use the DKA flow chart and you don't look for the sign of cerebral edema, and if you use the ketonuria as an endpoint to determine resolution of DKA. Why? Because the beta hydroxybutyric acid itself, it is be converted to acetone, and the acetone the one you measure in the urine. So your patient may be out of DKA, and for a couple of hours the urine show acetone. So don't use ketonuria to determine the resolution of DKA. And if you don't use the clinical judgment, really it is pitfall. So you have to use your clinical judgment. This is the DKA flow sheet. Clinical and biochemical monitoring is very important, as I mentioned before. important calculation. You can come across it. Is important for you. Anion gap, and the importance of the anion gap, because if you consider this patient is needing another bolus because he's not responding, the acidosis is not improved, and you are not 100% sure is it really the patient having prolonged capillary refilling. The objective, if you measure the anion gap, because the normal anion gap is 12 plus minus 2, and in patient with DKA the anion gap is 20 to 30 millimole. So if the anion gap is 35 millimole or more, this is lactic acidosis, so your patient is need more fluid. And corrected sodium, again, it is a good calculation, and the effective is molarity. طيب oral fluid should be introduced when clinical improvement have occurred. لانه بعض الزملاء يسالوا انه والله المريض قبل ما يبقى out of DKA but he is improved, he ask about the fluid. Can I give him sip of fluid? Yes, you can give him a small amount of fluid. When oral fluid is tolerated, IV fluid should be reduced gradually. But if the patient is out of DKA, يعني a clinical practice is now the patient is out of DKA. How? His bicarb is 18 or more, and his pH is more than 7.3. So you decide your patient is out DKA. What is the instruction you are going to write to the nurse? The instruction is first, give this patient, the first instruction, give this patient the sub-Q insulin. And then we come to stop after how many hours usually you stop. So you give the sub-Q insulin, and you give the patient the food. So I give sub-Q insulin. After how many hours I need to DC the IV insulin? You need to DC the IV insulin based on the onset of action of the sub-Q insulin you give. مثلا, if you give the rapid acting insulin or you give regular insulin, usually we set DC after 30 minutes. But if you give the patient MPH, so the MPH needs 3 hours to work. So you don't DC the IV insulin unless 2 hours minimally pass. If you give the patient only lactose, he's less than his 2 years, and you need to give him just only lactose, that means glargine. Again, you DC the IV insulin after 2 hours. So after how many minutes or hour I will decide to stop the IV insulin based on the action or the onset of action of the insulin you give. So usually we tell the nurse like that, give the sub-Q insulin. Usually it is no rapid or rapid acting, third, and after 15 minutes give the patient food to eat. If the patient tolerating the food, and 30 minutes pass from the injection, DC the IV insulin. And if the patient taking his whole meals, reduce the IV fluid by 50%, and then wait for 1 hour. If no vomiting, you can DC the IV fluid. So this is how you order your management concerning the introduction of sub-Q insulin and the oral fluid. طيب دي تكلمنا عنها. Morbidity and mortality, it's not important. Cerebral edema, we need to talk about it a little bit because it's notorious complications. Mortality rate goes up to 24%. Usually develop within the first 12 hours after treatment. The first 12 hours. Rarely it can occur 24 hours to 44 hours after the start of treatment. Or in a very, very rare situation, it may appear before treatment. طيب, risk factor for cerebral edema, if the patient has severe hypocapnia at presentation, BCO2 less than 21, high urea at presentation, severe acidosis at presentation, if you use bicarbonate, and if you administer the insulin in the first hour of fluid treatment. It have diagnostic criteria, and it have major criteria, and it have minor criteria. For sure, no one need to memorize the diagnostic, the major and minor, because it's something you can find it on any website. Just write diagnostic, but what you need to do to know is a practical point. So diagnostic criteria is abnormal motor verbal response to the pain, decorticate, decerebrate posturing, cranial nerve palsy, abnormal neurological respiratory pattern, اللي هي كان زمان cosmal breathing يبقى الان كاينوستوك. Major criteria and the minor criteria. How we diagnose? Despite severe dehydration, diagnosis. How we diagnose cerebral edema? One diagnostic criteria is enough to diagnose cerebral edema. Or you need 2 major criteria, or 1 major and 2 minor. This is what you need to know. So this is the criterion is having a sensitivity of 95 and false positive rate of only 4%. So it is useful. Signs that occur before treatment should not be considered in diagnosis of cerebral edema. This مقبل قلنا الهيدك. Neuroimaging is not required for diagnosis of cerebral edema. يعني لا don't rush your patient to CT. CT is not used to diagnose cerebral edema. Why we need to do CT? We need to do CT for certain reason. طيب action plan exclude hypoglycemia. Is it cerebral edema? Manage cerebral edema. Initiate treatment as soon as the condition is suspected. يعني if you suspect cerebral edema, start the management, consult your senior. If you start the management, the patient is not going to be injured or harmed, but if you delay the management, the patient is going to be harmed, in harm. So initiate treatment as soon as possible. Give mannitol in a dose of 0.5 to 1 gram, and or hypertonic saline 2.5 to 5 ml per kg. طيب consider continuation of mannitol infusion every 0.2 per kg per hour to prevent rebound increase in intracranial pressure, or repeat a policies every 6 hours. يعني ندي 1 جرام per kg. طيب بيشتغل بعد كم؟ After how many minutes I expect to see an improvement in my patient? 30 minutes. So if 30 minutes pass and your patient is not showing any improvement, you can give another bolus, or you can give an alternatively hypertonic saline. Type adjust fluid administration rate as needed to maintain normal blood pressure. Elevate the head of the bed to 30. Call your senior. Move to ICU. Intubate only in impending respiratory failure. And if you need to intubate, ask the most senior one to do it. Consider imaging after stabilization. Why? As I mentioned, we do imaging not to diagnose cerebral edema. We do imaging to look for the complication of cerebral edema, thrombosis, infarction, hemorrhage. Because a normal CT does not exclude cerebral edema, and the presence of cerebral edema in CT in a normal child, it doesn't mean the patient is having cerebral edema. Take home message: detailed history and examination is crucial. Careful interpretation of the investigation is paramount. Assessment of hydration status and slowly correction is vital. Total body potassium is always total body potassium is always low, and correction of acidosis priorities. Call your senior early. Get sure insulin is running when you transfer your patient, and exclude hypoglycemia when you suspect cerebral edema. And clinical judgment should always be used to determine the optimum treatment for individual patients. Thank you for your attention, and صلى الله على سيدنا محمد عدد ما ذكره الذاكرون وغفل عن ذكره الغافلون. ألو محمد.